It's neuropharmacology, antipsychotics part 2. In the previous video we talked about typical antipsychotics. Today, atypical. Here is a case for you. Please pause. Let's dissect that. So, this is Parkinson's disease and the patient is young and mild symptoms. Symptoms are mild, patient is young, and it's Parkinson. What do? Don't say L-dopa carbidopa because we try to preserve this for the old age because these are strong. I will go with a simple dopamine receptor agonist, and the correct answer here is A, rotigotine. Here is another case for you. Please pause. Now here is the patient 65, so old, late stage, severe Parkinson's, unable to take care of himself, requires 24/7 nursing care. He tried every single medication on earth, but to no avail. The patient would like to try anything that will reduce his symptoms. Which of the following option is appropriate? And the answer here is deep brain stimulation. Another case, please pause. So 31, he's no longer himself, so probably a psychological problem. I'm afraid of aliens, bizarre delusions, appears disheveled, psychiatric issue. Elephant in the room, I'm seeing and hearing stuff, hallucinations. You started the patient on medication X. 10 days later, he complains of involuntary muscle twitchings, facial grimacing, frequent blinking, tongue protrusion, restlessness, and tremors. What was the medication X that caused all of these bad symptoms? And the answer here is choose any typical antipsychotics. So it is F, Pemozide. What is the most likely mechanism of these symptoms that you saw in the patient after giving the drug? Please pause. And the answer here, of course, is blockade of the D2 dopamine receptors. These symptoms are called extrapyramidal symptoms caused by blocking D2 using a typical antipsychotic. Okay, medicosis, I have a question for you. Can we see these extrapyramidal symptoms with atypical antipsychotics? The answer is yes, although it is more likely with typicals than the atypicals. What is the problem in schizophrenia? Too much dopamine in the system, specifically in the mesocortical limbic pathway. These are the extrapyramidal symptoms. They happen mostly with the typical antipsychotics, but they can still happen with the atypicals, although to a lesser extent. It's important that you memorize all of the extrapyramidal symptoms with the time frame and the treatment options. Now it's time for the atypical antipsychotics. They are the number one choice for schizophrenia. These are the new generation. They have replaced the typicals as the treatment of choice because typicals, although strong, have bazillion side effects. They have many different mechanisms. Some of them are not clear, but basically antagonizing the serotonin 2A receptor. Please watch the previous video. When you antagonize the 5-HT2A receptor, this will increase dopamine, and this will improve the negative symptoms, decrease the risk of extrapyramidal symptoms, and decrease the risk of hyperprolactinemia. Also, they are weak antagonists of the D2 receptor. This will improve positive symptoms to a certain extent. All of the atypical antipsychotic have a nasty side effect of prolonging the QT interval on EKG. These are your atypical antipsychotics: clozapine, olanzapine, risperidone, aripiprazole, quetiapine, ziprasidone. Clozapine, what's the mechanism? I block 5-HT2A, I block D4. Side effects, agranulocytosis, very common. With clozapine, you need to keep a close eye on the CBC because of the agranulocytosis. What are the granulocytes? Ben, basophils, eosinophils, and most importantly, neutrophils. This drug can lead to neutropenia, which increases your risk of infection. It can lead to weight gain and metabolic syndrome. And here is a tip for you. Any drug that ends in apine is going to cause weight gain and metabolic syndrome. Next, clozapine can lead to seizure, hypersalivation. It does not lead to tardive dyskinesia. Awesome! But it can prolong the QTC. Yeah, any one of them can prolong your QT interval. Olanzapine mechanism, I inhibit the 5-HT2A serotonin receptor. This will increase the dopamine and improve some negative symptoms. Side effects, it ends in apine, therefore weight gain and metabolic syndrome, seizures can happen, and prolongation. Risperidone, I block the 5-HT2A, but I also block alpha-1. If you block alpha-1, you will lead to hypotension, orthostatic hypotension, and if there is slight blockade of the D2 receptor, you can lead to hyperprolactinemia. Aripiprazole, I block serotonin 2A and serotonin 1A. I'm also a partial agonist on D2. You can use me for schizophrenia, mania, and autism. I can prolong the QT interval. Quetiapine, I block H1 histaminic receptor and alpha-1. I have no muscarinic antagonism. Awesome. But since I'm an apine, I can lead to weight gain and metabolic syndrome. Ziprasidone, I block everything. I block the serotonin receptor, the dopamine receptors, like all of them, and I block the reuptake of serotonin. And I prolong your QT interval. These are your typical antipsychotic medications and your atypical antipsychotic drugs. And here is a case for you. Please pause. So here is a male comes in because he's no longer himself, hallucinations, delusion. In other words, he has schizophrenia. And then you gave the patient a drug and sent them home. After this, the patient presents with high fever, hypertension, tachycardia. On physical exam, there is muscle rigidity, facial flushing, skin flushing, excessive sweating, decreased bilateral deep tendon reflexes. The mini-mental status exam is positive for psychomotor agitation. Lab results show elevated liver transaminases. These are the ALT and the AST, high creatinine, and elevated creatine phosphokinase, which means muscle destruction. Besides hemodynamic stabilization, which of the following drugs will help? First of all, what is this disease? This is neuroleptic malignant syndrome as a side effect of a typical antipsychotic. So what do you do for neuroleptic malignant syndrome? You need to calm the patient down because this is an emergency. Give lorazepam to calm the patient down, to treat the agitation. Give dantrolene to take care of the muscles. You chose dantrolene, but oops, you found out that it's not available in your small town. What's the next step in management? If I do not have dantrolene, I'll go with bromocriptine or amantadine or both, depending on the severity of the case. Why is this? Hey, what caused neuroleptic malignant syndrome? Inhibiting the D2 receptor. I have too little dopamine. Therefore, to treat it, give dopamine, give dopamine. Bromocriptine is a dopamine agonist, amantadine is also a dopamine agonist and a reuptake inhibitor. Watch my video on Parkinson drugs. We'll see you in the next video.